Just a little bit. I want to make sure that I can get this all on the screen. You might hear my dog in the background, but all right. So we're going to go ahead. One of the topics, what I'm going to kind of discuss today, I'm going to make key points, the clinical process and its limitation. So, and I think the big part is limitations. So if you are a nurse practitioner or a nurse on the floor, or nurse in a primary care setting, wherever you are, it's important to understand that human memory is often an issue. And I'm going to read you this excerpt. I'm actually reading from a professor, and I'm getting ready to start back up school for the fall. And I like to go through the book and just kind of the book that I'm going to be using and go over key points of things. But I want to talk to you a little bit about some of these limitations. I'm actually going to read from the book here. Human Memory and Limitations. One of the most useful models for understanding diagnostic reasoning is the information process model. This model is built on the premise that human brain has both short and long-term memory, and that these forms of memory are different from each other. Short-term memory is a processing space that hold new pieces of information and elements of the patient history and physical data. It has limitations of being able to hold only approximately 7 bits of information, whatever that means. Much of the mental activity used in diagnostic reasoning is done to maximize the active process space and also to cluster or chunk cues into collection of data that can be managed together, which helps maximize process capacity. So with the human memory, the important thing to maybe think about to look at is that when you ask a patient, when you're going into a room and you're going to ask a patient, when did your symptoms start, or how long has this been going on for? They may tell you, 2 days ago. And then all of a sudden later in the interview, when you're examining and going over things, they're like, oh, well, I had this a week ago. So you want to make sure to try to continuously, in different forms and different ways, try to see if there was anything else that happened prior to that. And also maybe even have them ask them, if you keep on asking them the same question over and over again, like, when did this start? They're going to get probably irritated. But if you ask it in different ways, sometimes that can help. I've had, especially things like, for instance, if you have a patient who has coming in with sinus complaints, and they're telling you that I've had pressure in my sinuses, my frontal sinuses for, 5 days now. Well, typically bacterial sinus infection, the kind you get an antibiotic for, or kind that we treat with antibiotics, it's not usually going to be seen in 5 days. Usually it's past 7 to 10 days. And there's other things that go along with that. But so a lot of times what I'll start doing is I'll start probing and asking for more questions. Like, did they have an upper respiratory infection the week prior to that? Were they having allergy-like symptoms prior to that? Were they sneezing a lot? Were they feeling congested prior to those 5 days? And so I think it's important to understand that that you are going to have to sometimes ask things in different ways because of human memory and how much that is often forgot when you are trying to collect information from a patient. So the other thing is the critical thinking process. So obviously, I always like to think of nurse practitioners, nurses on the floor, wherever you work, in hospital or whatnot, is we are somewhat of detectives, right? We try to figure out, we try to figure the puzzle. We try to figure out what's missing. We don't always have the answers when patients come on into the clinic or the hospital. And so we want to use diagnostic reasoning. I guess I should take that off of there. There's no perfect test, and we're not treating, I always tell patients that we are not treating a test, we're treating the patient, right? And so diagnostic reasoning, per Dunphy, can be seen as a kind of critical thinking. Now, critical thinking has been defined as reflective thinking because the process involves questioning one's thinking to determine whether all possible avenues have been explored and whether the conclusions that are being drawn are based on evidence. This kind of thinking supports clinical judgment in several ways. First, it becomes a habit of the mind to have humility about one's thought process and to know that even the most experienced thinkers can make mistakes. Second, it becomes a systematic way of generating creative ways of thinking about a problem. Third, creative thinking returns one to an examination of the strengths of the evidence for a given conclusion. Evidence is the context means more than hard data such as laboratory values. Because as we all know, laboratory data isn't always correct. Sometimes you could have a patient that comes in with normal labs and they have something big going on. Even laboratory values must be examined critically when they are used to assist diagnostic reasoning. The type of evidence that is useful includes subjective impression of the ways that the patient's presenting themselves. So for instance, something like let's say if a patient came in with like severe abdominal pain and everyone's just thinking, oh, it's constipation, or maybe they have a small bowel obstruction. Often things like mesenteric ischemia, the abdominal pain will be out of proportion to the presenting symptoms, what the patient's telling you, what their objective data is going on, what the tests are showing. So it's important to consider that. The patient's initial complaint may be fatigue, but any patient who presents with bone-chilling inability to generate energy for daily living compared with fulfilled fatigue that comes in after challenging situation is completed is providing data that the clinician can use to investigate potentially serious health problems. So it's a way of critical thinking really is a creative way of thinking. And we can really, we can look at both long-term memory and short-term memory. This is a big one. And I always feel that this is one that I always call it the sixth sense, intuition. It is really a way that something that I feel like I've just been able to tell when something isn't right, when a patient that I know that I've been seeing for a long period of time that they need help. So sometimes I've even reached out to a patient because I'm very concerned about them. Or when I worked as a nurse on the floor, I would think, I need to go check on 432 because I'm concerned that they might be up and walking around and they are high fall risk. So my intuition is something that led me to preventing a lot of different things. And that's the way that we can look at intuition. Sometimes I don't like the fact that my intuition is so on point sometimes, because sometimes I do know that it makes me almost overthink everything. And so, but that is something. And over time, and if it is something that you are like, why am I thinking this? It's better to check and double check to make sure, and coming up with set types of routines for yourself. I always use I had an experience once years and years ago when I was a property manager. I was in my 20s and it was a property that was like 80 units or something like that. And I also lived in the property, and someone below me had they smoked some different kinds of things, and it actually somehow caught our unit on fire. And so I remember I needed my keys. Obviously, we're calling 911 and all of that, but I needed my keys because we needed to be able to have access to the keys. And I couldn't find them. I didn't ever have a particular place that I put them. And so the thing about that is ever since that time, now I always jingle my keys and I have a specific place that I put them. So it's kind of like coming up with things like that. This is definitely something. I'm reading, are you a psychiatrist? I am a nurse practitioner and a doctor of nurse practice. And I also am a professor as well. And so the other thing that is really important is developing expertise. So I think that this is an important thing for us to really, there was an individual who said, oh, you should just stay in the same place. They had been there for 20 years. And although I definitely admire people who can stay in the same place for a long time, I think that sometimes we can expand our knowledge by trying different things. So if you work on a unit that you really love, maybe trying different PRN jobs. Not that I think that we should be overworking ourselves and having 4 jobs, but this is one of the ways that you can kind of, if you know that analogy of the elephant where you're blindfolded and you're kind of touching different parts of the elephant, when you have PRN jobs or other jobs, it really does help you to be able to see the bigger picture. I've worked in so many variety of different settings, including things like hospital medicine. I worked as NP hospitalist for years and absolutely love that, but it's something completely different than primary care in ways. And so, but they go hand in hand. And I was able to see how primary care is connected to hospital medicine and how I can take care of my patients better when they get out of the hospital, or how I can prevent them from going into the hospital. So it was really kind of a fascinating dynamic that I had when I was an MP hospitalist, and then I went to primary care and I switched the MP hospitalist to just PRN. And it was just really fascinating, the things that I had the experience to be able to know that, okay, I can send them as a direct admit if I feel like that's necessary. So there's a lot of different aspects of and positive benefits to going to work at different places. So it really does help with your clinical judgment. So I think that's an important thing. So these are basically just the clinical process and some of the limitations. To go over some of the limitations just real quickly. Human memory, obviously, that's a big one that sometimes we can't guarantee on human memory. I mean, people forget things, they change their mind, they question themselves. So that's a limitation of that. Critical thinking. We definitely want people to think critically, but we don't want people also to think they have to chase after every single zebra. I think that's something that sometimes in the beginning we all get, we miss the most basic of things, because even something like Bell's palsy, that could be mistaken for a stroke. But of course, better safe than sorry, better to make sure that you're ruling out different things. And then diagnostic reasoning. That is definitely something we don't want to rely on tests, though. We don't want to just assume that the test is right. Once again, I say that because they can be wrong. So don't rely too much on tests. You may have to re-image, you may have to do other tests just to confirm, to make sure, and you may have to repeat tests as well. Intuition. Sometimes we second guess ourselves, and I think that's probably the biggest issue or limitation here with intuition is we either will like second guess ourselves too much or not at all. And I think that's sometimes is you got to find that balance in that. So that could be the limitation there. And then developing expertise. Well, do you stay somewhere for 20 years or do you try several different places and get little bits of information? So that's a tough one, because this is definitely my opinion on this. I think that if you are in a specialty area, you're going to learn that really well. But people also, you got to think about humans. They also get very burnt out. And so I think sometimes changing it up and doing different things can be very helpful. Well, I'm going to go ahead and head off for now, and I might be back later, but I wanted to go ahead and just read this because I thought it was an important thing. So.